Hello, welcome to this first of 5 lectures on dopamine blocking drugs, also known colloquially as antipsychotics, a term that is increasingly outdated as we use these medications for multiple indications outside of psychosis. So what I want to try and accomplish in the next 5 lectures is to give you a framework for understanding how these drugs work, both their benefits and their side effects, focusing on where they attach to receptors. So this is really going to be a chance where we get to use some of that knowledge that we got from the pharmacodynamic lecture, talking about receptor pharmacology to understand where these drugs actually cause an action. And this will also help us to understand their side effect profile as well. Obviously, there are over, I think, 10 or 12 different, even second generation antipsychotics, and probably twice as many of first generation antipsychotics. So this is not going to be a comprehensive lecture. What I'm going to give you is prototypical drugs for each of these classes, focusing on low, medium, and high potency agents. But first, a little bit of history, because we don't do very much history in our clinical training programs. And I think that's too bad, because there's the opportunity to learn from our mistakes of the past. So antipsychotics are obviously a fairly recent invention. They came about in the 1960s, really, 1950s. And before that, we didn't have a whole lot to offer people with serious mental illness. We essentially had custodial care in the form of asylums. And we had things such as hot and cold baths and ECT starting in the 1940s. Before that, we did insulin shock therapy. But we really didn't have medications until the first generation antipsychotics came about beginning in 1952, when chlorpromazine, which later became known as Thorazine, was synthesized. And this began a slow but fairly precipitous trend towards what is now referred to as deinstitutionalization. So this is moving people from custodial care of the state and state hospitals into communities with the help, ideally, of medications to manage symptoms. I'll leave it to you to decide how well that has worked out. Now, the first generation antipsychotics were very effective for positive symptoms such as hallucinations or paranoia, but they often left people with these stigmatizing side effects in the form of movement disorders, such as tardive dyskinesia, which we'll talk more about later. And then in the late 1980s, clozapine was the first second generation antipsychotic, and we'll talk about why that's different than the first generation antipsychotics. And there was a rapid rollout of medications modeled on clozapine in the 1990s, and even as recently as 2 years ago, when lumateperone was released. So they're still coming out. And these are generally effective medications. They often are very expensive medications when they come out. And it's thought that they are somewhat better for negative symptoms, such as withdrawal and some of the mood symptoms that go along with schizophrenia. Now, tardive dyskinesia was less of a problem, but metabolic issues became more of a problem, such as obesity and diabetes. So in order to understand how antipsychotics work, we have to understand where they work in the brain. And in order to understand that, you have to understand that there are 4 different pathways through which dopamine signals in the brain. And if you understand this, then you can start to understand how they have benefit and also where they have side effects. And we'll talk more about that as we go through this. So the key pathway to understand in schizophrenia is the mesolimbic pathway. So this is a connection. Meso means medium, so it's coming from the pons area in the midbrain, going to the limbic area of the brain. So this is the area that controls emotion and such. So the limbic area, so midbrain to the limbic area. The mesocortical goes from midbrain into the cortex, this wrinkly part that when we think of a brain. And this influences things such as negative symptoms, such as avolition, social withdrawal, and also some of the cognitive impairment that we see in schizophrenia. So we want to preserve dopamine activity there, while maybe dampening it down in an overactive mesolimbic pathway. Now, dopamine also has effects on movement through the Niagara striatal pathway. This is affected, of course, in Parkinson's disease, which will make sense as to why some of our medications give Parkinsonian-like symptoms when we block dopamine there. And then finally, the tuberoinfundibular pathway regulates lactation and breast development, so that through the release of prolactin. So that's an area that dopamine also has some influence that we can disturb through the use of dopamine blocking medications and cause untoward side effects, which we'll talk about in a moment. So in schizophrenia, it's thought that this overactivity of the mesolimbic dopamine pathway is what is responsible for these positive symptoms. So if you remember to symptom taxonomy with schizophrenia, positive symptoms are called that not because that they're good, it's not a judgment call, but because they're added to the person's consciousness. So this might be things such as hearing voices or having delusional thought patterns are considered positive symptoms of schizophrenia, and they're thought to be related to overactivity of the mesolimbic dopamine pathways. But underactivity of dopamine in the mesocortical tracts, so this is connecting the midbrain to the wrinkly cortex, is thought to contribute to negative symptoms of schizophrenia, such as social withdrawal, low mood, and negative symptoms such as avolition and withdrawal. Also, in some of the cognitive impairment that we see in people with schizophrenia is thought to be related to underactivity of dopamine in the mesocortical tracts. So you can see we're starting to have a little bit of a challenge here when we think about treating this, because we've got too much activity in one pathway and too little activity in the other. So if we block in one pathway, we could end up causing more problems in one area, but if we don't block it, then we continue to have the psychotic symptoms. More on that in a moment. Now, in everyone, we have the regulation of movement through dopamine influence on the Niagara striatal pathway. And as I mentioned a moment ago, breast milk development and breast tissue development is influenced through prolactin release in the tuberoinfundibular pathway, which essentially connects the pituitary gland. Now, to understand dopamine, we have to understand that there are 5 different receptors for dopamine. They're divided into 2 families, very unimaginatively named, the D1-like family and the D2-like family. So not surprisingly, in the D1-like family is D1, the dopamine 1 receptor, also dopamine 5 receptors. In the dopamine 2 pathway, or dopamine 2 receptors, I should say, we have D2, D3, and D4. The D1 receptor, when we block that, we get Parkinsonian type symptoms, such as bradykinesia, mask-like faces, and difficulty initiating movement. When we block the D2 receptor, we decrease psychotic symptoms. Blocking D2, incidentally, also suppresses the release of acetylcholine, which, as you remember, has an influence over cognition from our earlier lecture. In order to understand second-generation antipsychotics, we also have to understand serotonin receptors. So with serotonin receptors, there's even more to think about. So we have 7 main families and then some subfamilies. So serotonin, so 5-HT refers to 5-hydroxytryptophan, which is shorthand for serotonin. So when you see 5-HT, that means serotonin. And you'll see them with this subtext of 5-HT1, and then there's a subtext to that. So 5-HT1A, 1B, 1C. Sometimes just for shorthand, they'll be referred to as 1A or something like that. There's also subfamilies in the serotonin 2. So we have 2A, 2B, and 2C. The 2A family, the 2A receptor is going to be particularly important when we're talking about antipsychotics in the second generation, because when we block that receptor, we actually cause increased dopamine release in the mesocortical tract. So you can see where this is starting to go. When we activate the serotonin 1A receptor, that's a similar mechanism to what buspirone does, for example, and that's thought to increase mood and decrease anxiety. So some of these antipsychotics, particularly the second generation ones, have activity on the serotonin 1A receptor. The serotonin 2C receptor, when we block that, we also get some increase in mood, some improvement in mood, but we can also see increase in weight. And then finally, serotonin 6, by blocking that, we see increase in mood, improvement in cognition, and decrease in anxiety. And by blocking the serotonin 7 receptor, there can be some improvement in mood and possibly improvement in cognition as well. And then finally, serotonin 3 is the receptor that is blocked by a drug that you're probably familiar with from primary care, which is ondansetron or Zofran. So blocking that receptor decreases nausea. So you can see that these receptors, of which there are many, have influence in many different areas of mental and physiologic function. Now let's go back to something that you learned in the second week of class. So this has to do with the potency of a drug. So there's a couple different ways we can think of potency. The first one is its binding coefficient. So how sticky is that drug on a receptor? And if you recall, that is measured in something called Ki, which is known as the inhibitory constant. So this is an inverted scale. So the lower the Ki, the more sticky that drug is to the receptor. So we sometimes call the drug a ligand. It's the thing that sticks to the receptor. Okay. So a high potency drug, often such as haloperidol, requires a lower dose than a lower potency drug, such as chlorpromazine, because that drug, that molecule, sticks to its target more tightly. It's a more potent drug. And there's another type of way of thinking about potency, which is activity, which is how much does the drug, once it's attached to its receptor, does it activate or block the receptor? And so we can think of this as a spectrum. It's not an either or. I'll talk about that in a second, but a way of thinking about affinity, the stickiness, is kind of like the difference between this lazy boy recliner and these lousy benches that you have at bus stops, right? So a drug with a high binding affinity, it's like this really happy guy. He looks really happy in that recliner on the receptor. So if that lazy boy chair is the D2 receptor and that man is haloperidol, he's going to sit there for a while. He's not going anywhere, right? So he's got high affinity for that receptor. Now, something like quetiapine has low binding affinity. What it probably does, it sits down for a minute, like this lady waiting for a bus. As soon as the bus comes, it gets up and moves on, right? So it comes by, drops by for a second, drifts away. So this would be something like quetiapine or Seroquel, which is a low potency agent on the D2 receptor. So this stickiness is one way of thinking about potency. The other way we think about potency is what does it do when it actually gets on the receptor? So we can think about activity at a receptor. So remember we talked about agonism, antagonism, partial agonism, partial antagonism in one of the earlier lectures. So we can think of this as a little bit like a speedometer. It's not a perfect analogy, but work with me here. So we can think of, say 65 miles an hour as the normal rate at which this receptor works at. So this is kind of its basal rate. We're going to say it's going boop, 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 boop at its normal firing rate. Because remember, there's that basic or basal firing rate that all neurons have. Now, if we totally activate that receptor, that's what we call a full agonist. So now instead of that normal boop, 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 right, it's going boop, 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 boop. Okay, so we've really turned it up high. You can think of this as like a rheostat too, like your dimmer switch on your lights. Now we've turned it up all the way to full brightness. Now, partial agonist is somewhere between that full agonism and its basal firing rate. So now instead of the normal firing rate of boop, 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 it's boop, 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 but it's not the boop, 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 boop that you get of the full agonist, okay? So somewhere between those two. Now we can have something called an agonist. So an agonist, if you recall, is like those little childproof plates you put onto your outlet in your house when you have kids around. What that basically does is it prevents the receptor from being activated. So it's just sitting on there and preventing activity from happening. And then you get this thing that is confusing, which is referred to as a inverse agonist. And so an inverse agonist it actually causes the whatever that receptor does to work in reverse. And I find this a challenging concept to grok, but it's a little more than an antagonist. So it's not a neutral antagonist. It's actually causing the receptor to do whatever it does in reverse. So you'll hear that sometimes referred to with antipsychotics, that it might be an inverse agonist on a receptor. Now, don't freak out. We're going to decode this. So one of the ways that we can start to predict the activity of a drug, both its effect and side effects, is by looking at this binding affinity. So these are those KIs. So remember, smaller number means more sticky. And we can start to compare and contrast drugs. So let's take an example such as haloperidol, Haldol. You're probably familiar with this. So we're looking at the D2 receptor here in this column, and we're going to come down and we say it's 1.4. Okay, so that's a pretty low number. That means haloperidol likes to stick to that receptor. And we can compare it to something like quetiapine or Seroquel, which, as I mentioned in the lazy boy bus seat analogy, is much less sticky on that D2 receptor. So its binding affinity, or Ki, is 310. So it's many fold less than haloperidol. So it is a much less potent drug at that receptor. Let's take a look at some other examples, looking now at side effects. So this is the acetylcholine, that's what ACH stands for, muscarinic receptor. So if you recall, there's two types of acetylcholine receptors. There's nicotinic and muscarinic. So most of the ones, when we say something has an anticholinergic effect, that usually means it's blocking the muscarinic receptors. And that causes things such as dry mouth, urinary retention, blurry vision, and such. So let's take a drug like haloperidol, which has very little activity on the muscarinic receptors. In fact, its Ki is almost 5,000, which is sort of the point where we say it hardly sticks at all. But let's look at a drug like clozapine, which was the very first prototypic atypical antipsychotic or second generation antipsychotic. It has much more affinity for that muscarinic receptor. So you can predict that that clozapine is going to have many more of those anticholinergic side effects, such as dry mouth and urinary retention, compared to something like haloperidol. Again, let's look at another side effect, antihistaminic effects. So this is how much does it block and stick to the H1 receptor in the brain. So a drug such as quetiapine, for example, has very little, actually, I'm sorry, I take that back. It actually has a fair amount comparatively of these antihistaminic effects. When we see that, so because its number is 19, so it's relatively sticky to that receptor. And not surprisingly, quetiapine comes with a lot of these antihistaminic side effects, such as sedation and weight gain. So we can start to look at a chart like this and then predict what kind of effects and side effects we're going to see. I'm going to use this chart repeatedly. I'm going to slice it down and only use portions of it in each of the drugs that I talk about ahead. You'll sometimes see these charts as a way of kind of simplifying what we saw in the previous chart. So rather than the quantitative data, they've kind of broken it down to these qualitative 1+, 2+, 3+ kind of ballpark figures. So this helps us to begin to predict what kind of side effects each drug is going to have. And we'll talk more about that in the next lecture. I'll see you there. Thanks.